at least 30% of the stomach radiated in the thorax, or if there is a paraesophageal hernia of at least 5 centimeters, the Yato defect, and also the type 4. And surgery is indicated for all symptomatic paraesophageal hernia, and in the emergency when you have an acute obstructive symptoms and the bowel. And you know that laparoscopic repair is considered the gold standard, hence the reduction of hospital stay, peripheral complication, readmission, also, and similar in hospital mortality with open surgery. But we have this problem, so an high recurrence rate from 7 to 50% of this problem. What about robots? Robotic surgery started in 2001 with the first robotic Nissen fundoplication for a gastric esophageal reflux disease. You know that all the advantages that the robotic surgery have in this kind of pathologies. But we know what is our experience, because we started in 2000 with laparoscopy, and when we started with robotic, you see that there was a shift from laparoscopy to robotic surgery. Why? Because the robotic surgery has a lot of advantages, especially in the dissection of the mediastinum, especially in difficult cases, especially in giant hernia, paracardial hernia. What about the key steps for robotic treatment of giant hiatal hernia? It's the same that in laparoscopy. You see the placement of the trocar. We have first the complete reduction of the hernia sac with a blunt mediastinal dissection. But you know what is the advantages to have endovascular instruments that work inside a very restricted space like this. Because you have to dissect the sac from pleura, you have to recognize the aorta, you have to have a very careful dissection of this space. You have to do an external esophageal mobilization, because the aim of our operation is to reposition the esophagus inside the abdomen with the tensionless intra-abdominal position of the gastroesophageal junction. Because if you don't do this, you made confession that I don't know if you constructed any recurrences. The hernia sac is generally completely removed to allow an optimal visualization of the gastroesophageal junction, to reduce post-operative seroma, and to reduce the risk of recurrences, and to perform a better cruroplasty on quality tissue. The crural closure is performed with or without the use of mesh, using non-absorbable suture, and in most cases, a partial fundoplication is performed. It's not necessary, but sometimes it's useful. The experience in the literature about the use of robots for treatment of giant hiatal hernia are not so large. You see that we have some experience, but with a little series of patients, and but what you can see, that the follow-up is not so long, about 15, 16 months, and that the recurrences after robotic surgery are reduced if compared with laparoscopic surgery. So what we can do, what we can say, that robotic assisted laparoscopic repair of large, or in case of difficult case we do hiatal hernia, we have a reduction of major complication rate and also mortality within 30 days. And that the robotic platform is useful, especially in difficult cases like redo procedures, previous intervention, patients with failed fundoplication, and obviously giant hiatal hernia. What about recurrences? The recurrences is not always a problem. Why? Because you can have different kinds of recurrences. Generally, the recurrences is anteriorly and sometimes posteriorly. When you have a posterior recurrences, generally is the disruption of your suture, and generally what you have in early recurrences. What about the rule for mesh reinforcement in this case? Is really useful or not? We can say from the data, from the literature, that really this is useful, especially to avoid early recurrences. When we have a long follow-up, the benefit in a long follow-up is reduced because we have the same incidence of recurrences. But the problem in this kind of surgery is not the late recurrences, but because generally the late recurrences are asymptomatic and not so large like the first defect. The problem is the early recurrences, especially when you have after the immediate postoperative period, because there is a problem of technique or a problem of tension. So generally, the recurrences doesn't depend from patient's characteristic or hernia characteristics or intraoperative technical factors, but depends from the experience of the surgeons and also from the annual volume of the centers that treat this kind of surgery. So we can use different kind of prostheses to repair, to reinforce the hiatus. But generally, the synthetic mesh has some problem, like regression, infection, erosion, postoperative dysphagia. Biological mesh is good, but perhaps is too expensive. And now we have also the biosynthetic mesh that have good results, long-term, fully resorbable, no collagen disposition, no vascularization, and tissue growth. So the use of mesh is evident, especially in the lower recurrences rate in early time. So the current data are too heterogeneous, and there are significant differences when comparing primary suturing with mesh reinforcement, but especially for avoiding early recurrences is useful. How to shape isosynthetic? It's very important to measure very well the area and to select the right dimension and the right shape of your mesh. And it's important to fix not using tacks or other not absorbable method, but only with some stitches and also glue tack, fibrin glue, what we want. But only to reinforce your area and to allow the growth of fibrous tissue. This is our experience till now. 94 patients treated with only giant hiatal hernia. And you see that 12% performed in emergency setting, sometimes associated procedures, and we use the mesh in 5 cases with Gore BioA, 9 cases PASIX ST, biosynthetic mesh, and only 1 case on reused permacoat. But generally, in the last period, we are using PASIX ST because it's more easy to manage inside the intraoperatively. Very good results in terms of postoperative complication. Only 12 recurrences, 12%, but see, only 1 reoperation. So the problem, the recurrences, is when we have to reoperate the patients. I want to show what is the case. This is the first operation is performed from surgeons that work with me, very experienced in this field, very large hiatal hernia, but we can see together some mistakes, some little mistakes that that are important in this case. You see very good dissection of the sac from the pleura without great problem. Using of only monopolar hook. You see here, the esophageal gastric junction is not so well reducted inside. And what this tissue is not the crura, is only the peritoneum over the crura. In the first postoperative day, we do the oral gastrography, and all the stomach is completely inside again in the mediastinum. Symptomatic patients, early recurrences, what we have to do? Robotic reduced surgery. This is the situation. It's not an easy case because we have to remove the adhesion. Perhaps waiting 7 days is not so good. We have to refer it before to avoid this. You see that all the esophageal gastric junction is again inside. The posterior wall is quite good, but anteriorly is completely open. The sac that was dissected before is again attached to the pleura. We put inside a probe to make a good calibration of the esophagus. Generally, we use a drain to make a gentle traction on the esophagus. You see the probe inside the esophagus. And then we go to make another reconstruction of the crura, taking well and better, if it's possible, the muscle, and not only the peritoneum that cover. But the tissue is not so strong, so we decided to use a biosynthetic mesh to reinforce the area. Measurement, very easy to decide the exact shape of our mesh. We introduce the physics ST inside. You know that there is a surface for the intra-abdominal position and a surface for the abdominal wall, in this case the diaphragm. We reinforce and we attach with some absorbable suture. Be careful because there are some reports in the literature with damage of pericardium and other not so good complications. So we put and then we cover with fibrin glue. And this is the result. The post-operative CT scan, very good. It is a pleural effusion without any problem. And now we have a 6 months follow-up without recurrences. So in this case, the use of robot, I think that could be very, very useful. So, robotic repair of giant hiatal hernia is not contraindicated. It presents encouraging results in terms of safety, feasibility, and risk of recurrences, especially in obese, radial procedures, and complex cases. Certainly, cost remains an important drawback associated to the use of robotic platform, And the evidence to establish robotic approach as the gold standard treatment is still lacking. But we hope that this will be resolved as soon as possible. Further randomized control trials are required to better standardize robotic repair. In Italy, we are starting with an Italian registry for the repair hiatus hernia. And further study investigating the long-term outcomes with bioabsorbable mesh while accounting characteristic of hernia, closure technique, post-operative outcomes are mandatory to make a definite conclusion. And I think really that the centralization of the management and the treatment of this rare pathology, like giant hiatal hernia, with the routine use of robotic system at a high-volume referral center, could be helpful in ensuring the best outcome to the patient